Oh, all right. Yeah. I know a lot of times I forget about things like that. Sure.
Hi, everybody. Welcome to Grand Rounds. It's a pleasure to introduce Robin Chang. I think most of you will recognize Robin from his work on the wards and in emergency on clinical service. Robin's other hat is working at UBC in the Alzheimer's Disease Clinic, where he holds the Ralph Fisher Professorship from the BC Alzheimer's Society. Robin finished his neurology in University of Washington, then did a movement disorder fellowship, then did a master's at UBC, I think it was health sciences and epidemiology, and then did a locum with us here, and then came on staff here a long time ago now, I think 2004, and has been working at UBC and working with us at St. Paul's since then. So Robin is very well respected nationally and internationally in genetics and Alzheimer's disease, and is going to talk to us today about can dementia be not cured but prevented. Thanks, Robin.
Thank you very much for your kind introduction. So I noticed that when I sent in my title, I said, can dementia be prevented? But I was reviewing the evidence. Dementia is too big a topic, so I reduced it to Alzheimer's. And I'll just show you in the next slides to differentiate what's different between dementia and Alzheimer's disease. So as this is a potentially, why is it not? As this is a potentially CME, I have to give you a disclosure that I've received different forms of funding. Some of those are commercial fundings for being a clinical trial site, which I will mention some of the clinical trials later on in my talk. But I don't think there will be much conflict of interest otherwise. So dementia is a huge umbrella term for all sorts of different diseases that causes cognitive impairment. So the exact definition is that it's a clinical state in which there is a loss of function in multiple cognitive domains that leads to a decline with everyday functioning. So it's a very broad term, and what do we mean by everyday functioning? That's also very fuzzy gray zone, and it leads people to interpret things differently, but it was deliberately left to be somewhat gray so that the clinician can use their own judgment when they diagnose people. Alzheimer's disease is the most common of all the dementia, probably responsible for about 2/3 of all the other dementias together. But there are other forms of dementia which I will not have time to go into, except maybe cerebrovascular disease. And when I talk about risk factors, it will be obvious that many of the cerebrovascular disease overlap with Alzheimer's disease, whereas I won't have time to talk about the other types of dementia. So now moving on to Alzheimer's disease, a lot of you have known that the first case of Alzheimer's disease was actually a young onset patient. So this lady named Augusta D was the first description by Dr. Alois Alzheimer. And at the age of 50, she started being forgetful, starting to have a change in personality, and also starting to have language problems, unable to name things, and also unable to understand language properly. So there are multiple clinical cognitive spheres involved. She also gets disoriented, unable to know her direction, and was having some, but otherwise neurologically she's normal. So in terms of movements, walking, she's otherwise normal. She died within 5 years at the age of 55. And Dr. Alzheimer's did his pathological studies. And he described these particular changes with plaques and tangles. So plaques are extracellular collection of protein. At that time, it was mostly stained with H&E and silver stain, so you can see them as a fuzzy area that is outside of the cell, whereas tau is a dark area stained by the silver stains inside the cell. And we now know that what these protein come from. So the amyloid protein is normally a membrane protein, very common in a lot of neurons, highly available in the synaptic junctions. So when people try to remember things and learn things, there's a lot of synaptic remodeling going on. So it's a very active place of the brain where synapses are constantly being remodeled. And maybe that's why memory is being affected the most in Alzheimer's disease. Tau is an intracellular neuronal protein that is inside the cell, mostly in the axons. So we now know that tau is a protein that is involved in the axonal structure. The axons needs to transport protein from the cell body to the end of the cell at the nerve ends. So when things are not getting through the axon properly, the health of the nerve may be affected. So based on these findings, we have proposed diagnosis of Alzheimer's patient, mostly still based on clinical diagnosis, because the biomarkers actually took us many years to do research. And just recently, in 2011, the diagnostic criteria has been updated to include the potential use of biomarkers, but it was left as optional at that time because it's not fully validated, and there are still some controversies on the different type of biomarkers, what are the best ones to be used. But the symptoms are similar to what Dr. Alzheimer's has already described in the first patients. The cognitive decline involves multiple domain, most commonly the memory domain, but not necessarily memory. Some people have posterior cortical atrophy with Alzheimer's changes, so they lose their visual spatial ability early on with relatively preserved memory, or people can have a progressive aphasia, so the part of the brain that governs the language could affect first before you lose the other types of memory. So it can be affecting a different part of the brain, but most commonly, memory, language, decision-making is what we call executive function. So we have to integrate all the different information and then make a decision to do something about it. So that's the decision-making or the executive function. Visual spatial, I mentioned, integrates the visual and the motor movements. And then motor planning, praxis, is another sphere of cognitive domain. As I mentioned, they have to be progressive from a previous level, and they're severe enough to affect daily activities. And then you can fulfill the current diagnostic criteria. But now, if there are biomarkers available, which includes spinal fluid analysis and PET imaging, and also structural brain imaging. So if you see certain parts of the brain that is becoming atrophic or shrinking, that may help you make a diagnosis. But at the current use with the diagnostic criteria, it's still optional. So most of you already know that. I don't have to say there's an increasing prevalence of dementia, usually because of the aging population. So this is particularly severe in the first world countries where people are living longer and longer, and this is really mostly an aging disease. But with some of the developing countries that are now living up longer and longer, there is a significant rise in the global prevalence of dementia. Incidence in North America is about 1 in 1,000 person years at the age of 55, but increased to about 80 per 1,000 person years at the age of 85. So it's, again, just shows you that it's more common as people get older. The cost of care is staggering. In a study back in 2013, the estimated cost is about $10 billion per year, and it's the third most costly disease to manage after heart disease and cancer. So it's a long-term disease, and people live with disability for a long time, so it's quite expensive to care for. So what do we know about Alzheimer's disease? I summarized it in this model just to show you all the different factors. There's now quite strong evidence that genetic factors contribute to Alzheimer's disease pathology. But the obvious one, those autosomal dominant ones caused by APP, called the Alzheimer precursor protein, or the presenilin 1 and presenilin 2, they are quite rare. So probably less than 5% of all the Alzheimer cases have one of these autosomal dominant mutation, in which when there is a mutation, then as long as you live long enough, you're most likely to get the disease. But the other genetic risk factors are more like genetic risks. So when you carry a risk, your baseline risk of developing disease is higher, but not everybody will get it. So it's not for certain that even if you carry a risk factor that you're going to get a disease. And that's more complex with the complex genetics. The strongest one that we know about is ApoE, which is involved in cholesterol metabolism and also vascular health. So I put it as part of the vascular risk factor. But high cholesterol, diabetes, and also hypertension. So these are the common vascular risk factors, also contributing to an independent risk for developing Alzheimer's disease. When you have these factors, the amyloid or precursor protein is cleaved to become an amyloid peptide, which is a short peptide, somewhere between 38 to 43 amino acids. And normally it's soluble, it's floating around in a monomer form, but it can aggregate into an oligomer. So when there are 2 to about 10 of these monomers sticking together, it becomes an oligomer. And when it becomes very big, then it becomes an aggregate, which becomes the amyloid plaque that are visible in the microscope. But with a lot of recent studies, it is suggested that it's the oligomer that is the most toxic form of amyloid. because a monomer at that time is not too bad. And after it's clumped together, we think that is actually stable, so it actually doesn't cause damage to the brain cell. It's the oligomer stage that is floating around that is really bad for the nerve cells. It inhibits synapses, causes a lot of metabolic problems in the cells. What we don't know about is how tau is involved in plaque and amyloid. Clearly, with increasing amount of amyloid, there is also an increased production of phosphorylated tau. But how these are linked is still unknown, and it may be one of the holy grail that we haven't found yet. But tau itself can cause different forms of dementia, and that's when things become very complex. There are different types of frontotemporal dementia that is caused by tau abnormality alone, and in those dementias, they don't have amyloid plaques. And I don't have time to go into the details. Another risk factors commonly described with Alzheimer's is environmental risk factors. Some of those are not really modifiable, which I'll talk about next, but some of them may be modifiable. So can we actually modify these modifiable risk factors to reduce Alzheimer's disease? That's one of the questions that is being studied, and I'll show you some of the data, which leads to the title of my talk. When you have a lot of these changes, eventually the synapses die. So there's the connection between the nerve cells, and when you don't have synapses, then your brain is not talking from one part to another, then you lose your memory. Yeah. There are modifiable and non-modifiable risk factors. For instance, everybody gets older. Unfortunately, that's the truth, and we cannot really change that. Sex is not something people want to change usually. And family history and genetics are generally you're born with, and it's as long as we're not using CRISPR technology to change our genes yet, we cannot really change our genetic composition, except if there are particular drug targets to one of these genetic changes, then maybe we can treat them with pharmacological agents. Level of education, it's a question mark because in general, people have achieved their highest level of education when they start working and have their career. But now we actually advocate lifelong learning. And the more people continue to use their brain and learn things, maybe learn a second language, third language, there's some evidence suggesting protective effects on the development of dementia. So maybe it is a modifiable risk factor. On the modifiable side, I have a question mark for depressive symptoms because it's also unclear at the moment. There's a lot of epidemiological evidence that late life depression increases the risk of developing Alzheimer's disease. And in contrast, a lot of patients with Alzheimer's disease in the early stage also develop depression. So what we don't know is whether it's a cause or effect. There's an association with increased depression with Alzheimer's, but we don't have any evidence that if you control the depression, you can actually delay Alzheimer's. But those studies have not been properly done, so it's still a question mark. But most of the other ones are the vascular risk factors, which I will spend about half of my talk talking about that now. And most of your internists will already recognize that these are the same risk factors for heart disease and stroke. And it only makes sense that if we want the brain to be healthy, we should try to reduce these risk factors. So there are a lot of epidemiological evidence looking at association between one of these risk factors and Alzheimer's, and I won't have time to go into those data. But some of the treatment data that came out recently with the PreD4 study, which is a large-scale hypertensive treatment, comparing aggressive treatment, which is to keep the systolic less than 120 versus a more traditional treatment, which is just to keep the systolic less than 140. And the actual publication hasn't come out yet, but it was described in a meeting, one of the Alzheimer's meeting in July last year. And the abstract is published, but the actual full paper is not published. But they showed that when you randomize people to a strict treatment of keeping a lower systolic blood pressure versus a more regular treatment of less than 140, the rate of development of mild cognitive impairment, which is usually what we describe as a precursor to Alzheimer's disease, is reduced by 20%, and it's just quite significant. And also following these people with MRI images, there's also a reduction in the amount of white matter changes overall. So it may be secondarily reducing what we call vascular cognitive impairment, but overall, when people are progressing slower, it's generally a good thing. And diabetes, again, there are a number of epidemiological studies showing association with poorly managed diabetes at worse risk of or worsening of Alzheimer's and dementia. And some of the different treatment, and in particular metformin and pioglitazone, shows that when we use these patients, comparing group randomized to receive treatment versus not, they have a better outcome when they're properly treated. We have conducted one study on aerobic exercises alone at UBC. It was led by Dr. Louis Ambrose, who is a professor in the Department of Physical Therapy. And we look at how aerobic exercise training compared to a placebo group, but because of the potential benefits of participating in a study and a social interaction, our placebo is not a complete placebo, but they actually went through cooking classes, and we teach them about the importance of diet and cholesterol, so that their diet may help to control their risk factors. But in the intervention group, they are subjected to 3 times a week aerobic exercises, which is actually walking, so very brisk walking. And there are trained physiotherapists and exercise therapists monitoring them and checking their heart rate to get them up to about 70% of their recommended exercise tolerance. So usually it goes up to about a heart rate of 140 or so. For at least 15 to 20 minutes. So it's actually quite a vigorous exercise regimen. And we get them together 3 times a week. We found that there is actually an improvement of minus 1.7 point in the ADAS-Cog, which is a memory test that we use to measure patients with Alzheimer's disease. And there's also some benefits, but this benefit did not carry over after the actual intervention is over. So there was a 6 months intervention, and then we asked them to keep on exercising, but then we didn't follow them and make sure they are actually exercising. We just follow them and we test them at 12 months, and it seems like that the benefit did not last after the study is over. But there are some other benefits. For instance, they have a weight reduction as well as better walking distance and decreased diastolic blood pressure. So there are some other measures that may suggest improvement of the general health. Then one of the larger studies, and that has been on the news quite a bit, is this multimodal intervention, which was the first one was done by a Finnish group, and it was an acronym called FINGER study, which stands for the Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability. It's a double-blind randomized trial comparing an intensive intervention versus normal. So normal is just counseling, tell them what is good health. If they have diabetes and hypertension, they're treated as usual, but that's about it. And then they are followed over time at 1 and 2 years. So looking at this protocol is actually quite intensive. When they exercise, they have to do up to 4 times a week, and there is a physiotherapist monitoring their exercise, and they are coached, and they make them go as much as they can 4 times a week throughout the 2 years. There is also a cognitive training. So this involves playing games, mathematical, arithmetic problems. So they have to do a lot of various things, as well as doing different types of puzzles. So they subject them to playing these puzzles regularly, several times a week in a group environment. And then there's also intervention of their vascular risk factors with a nurse following them throughout. So their blood pressure and their sugar level is monitored weekly. So these people are actually very intensively followed, and making sure that their vascular risk factors are controlled as much as they can. And it worked. So there were over 2,000 people screened, with about 1,200 people actually eligible, and about half of them got the intervention, half of them got the usual care. And you can see that there is a reduction in each of these outcome measures, including a total overall NTB, which is a neuropsychological test battery. So they combine a number of neuropsychological tests, which test memory, executive function, visual spatial skills, and they seem to be better in the exercise group. Surprisingly, memory actually was not statistically significant. So there's a trend, slightly better, but it did not reach a statistical significance. But other benefits include a better exercise function, executive function, and also better processing speed. So their decision-making is much better, and then the speed of doing all the information processing is faster. So there are some benefits, but those of you who are neurologists will realize that these are more the changes in the vascular cognitive impairment patients rather than pure Alzheimer's. So some people argue, well, if we're improving, these are really just reducing vascular risk factors and reducing the vascular cognitive impairment. But the other school of thought is that dementia is dementia. So as long as you can reduce their cognitive disability, it's an improvement. And based on epidemiological studies, vascular risk factors has an attributable risk of about 30% of all dementia. So it does affect a significant chunk, not all of the dementia, but if you can reduce it by 1/3, it's a significant success already. So they are being promoted based on these findings. Some of the secondary outcomes, just like any clinical trial, we look at adverse effects, and there are really very few adverse effects other than people complaining of muscle aches, which is for people who hasn't exercised for a while and they push them to exercise. It's normal to get some muscle aches. But there's no difference in behavioral or stress feeling, no difference in time loss, no difference in death and stroke risk. And there seems to be less heart attacks in the intervention group, so there may be other benefits as well. And a recent subgroup analysis looking at those who are ApoE4 carriers, which is a risk factors for having a certain type of cholesterol metabolism gene. And those people with an E4 are at higher risk of developing Alzheimer's disease. But when you subject them to the intervention program in this group, the benefits are also present. So it's independent of their genetic risk factor. But if you look at that intervention, how feasible it is. So now, after that one, there are a number of other studies also trying to replicate this finding, although the intervention is slightly different. So the MAPT study is from France, targeting an older population with 4 arms, multi-domain intervention plus omega-3, which is supposedly good for your heart and vascular health, versus omega-3 alone versus placebo. And their inclusion criteria are twofold. CAIDE, C-A-I-D-E, it's a score that rates your baseline body weight, body mass index, and your blood pressure and your cholesterol level. So based on these, and also their cognitive screening test score at baseline. So based on these, if you have increased a number of risk factors, then you're scored high. They are also including people who have positive amyloid scan. So this is a different way of identifying patients with potential Alzheimer's disease. But in this particular study, it was mostly negative. And looking at the protocol, they say that their intervention is not as rigorous, and they're told to exercise, but there's no one actually monitoring them, how much they exercise, things like that. So in this particular intervention study, it didn't seem to work. So there's another one called a PreD4 Study, which is initiated in the Netherlands. It's also a multi-domain with a nurse-led vascular risk intervention, so monitoring their blood pressure and diabetes and cholesterol, as well as giving them drugs as they need it, and promoting healthy lifestyles such as exercising. The overall intention to treat analysis was negative, but looking at this subgroup, with the subgroup that actually adhere to the intervention and those with a higher risk factor, CAIDE score seem to have significant improvements. So maybe these interventions only work if you actually have this risk factor. So thinking, can we apply it to Vancouver? And looking at our local epidemiology, Vancouver rates tend to be a fairly healthy group of people. So just in the general population, it's quite high. So the life expectancy is quite a bit older compared to the rest of Canada. I think it's at 87 in the last census. So maybe if you apply it to an already very healthy population, it may not make much difference. So there is some discussion where it would be how best to use the resources, because our health care dollars are limited. But I think as physicians, we should always promote it, where they follow it and how rigorous the regimen it is. It's up to the patient, and at the moment, we don't have the resources to force them to exercise and monitor their risk factors very closely. But I think it just makes sense to promote a healthy lifestyle and reduce these vascular risk factors as much as we can. So what about the pharmacological treatment? So I will move on to about some of the studies looking at disease-modifying therapy. And I must say that after 15 years in this area of research, I'm getting very jealous of all the MS doctors who have new treatments, so many new treatments for MS nowadays. And even stroke doctors now have new types of treatment for stroke. And we are falling behind, and we have to work very hard in getting some disease-modifying therapy. So most of the disease-modifying therapy is based on the amyloid hypothesis, because for ease of producing a mouse model, most of these mouse models are based on these mutations, the APP, PS1, and PS2. So these patients have early onset Alzheimer's disease. And when they put it into a mouse, the mouse get mouse Alzheimer's with these changes in the brain. For better or for worse, most of these treatments are based on amyloid, although some new tau therapy are coming out, but we don't have a lot of data on that yet. And the two ways to treat it is either when you form the amyloid, you try to remove it, and the most specific and effective way is by monoclonal antibodies. And another way is to stop the cleavage, which is this secretase or beta amyloid precursor protein cleavage enzyme. So BASE is an enzyme that cleaves the APP precursor into the different forms, including the amyloid. So if you slow down the cleavage, maybe you can slow down the production of amyloid. And that seems to work in the mouse model. So they are being tested in human. And in the very early Alzheimer's immunotherapy in a mouse model, these are the non-immunized mouse with a PreD4, which is a gene of APP that is knocked into the mouse, and they're producing excessive amyloid, and they produce these plaques that kind of look like human Alzheimer's changes in the brain. And if you immunize them, these mouse are protected from developing Alzheimer's despite carrying the gene. And there are also clinical data, or not clinical for the mouse, but behavioral data for the mouse on swimming around a maze. And these mouse that are treated are able to preserve their memory much better, kind of like a normal control, compared to the Alzheimer's mouse that by about 9 to 12 months of age, they start forgetting where to look for food and swim around a maze. So there's a significant difference in the mouse model. So based on these monoclonal antibodies, at UBC, we have probably carried out more than 10 related studies on monoclonal antibodies, or at least a theory of removing amyloid in the brain. And then there are some BASE inhibitors trials as well. Unfortunately, you can see that all of them are really negative or borderline, and I'll show you what those borderline are. So bapineuzumab was one of the first one that came out. It's a monoclonal antibody that is binding to different forms of amyloid oligomer. So it binds the monomer oligomer and also the aggregated amyloid as well. And the primary outcome is that we did not see any difference in their ADAS-Cog, which is their memory score, and there was no difference in the DAD, which is a functional measure, and there was no difference. But if we look at the subgroup, at that time, the use of biomarkers was not as common and was quite new. So it was only used as a subgroup. So those who are willing to have a PET scan are also included in this subgroup analysis. And it shows that a lot of the people who are PET positive are actually non-ApoE. No, sorry. So most of those that are PET positive have a high percentage of people who are ApoE4 carriers, whereas those who are PET negative has a significant percentage that are non-ApoE4 carriers. That suggests that there are probably a lot of phenocopy, some people who actually have some sort of memory impairment and they're diagnosed clinically as Alzheimer's disease, but they don't actually have the amyloid changes in the brain. So the possible interpretation is that we include these people with non-Alzheimer's pathology who are not likely to be beneficial. So it's diluting the outcome. So then there are another monoclonal antibody by a different company. And in this one, they included biomarkers for screening. But unfortunately, this one is still only a borderline. So after this one, there was a second and third follow-up study. And combining all the three studies together, then there is a borderline significance of 0.05. But if you look at each of these individual trials, there's a trend suggesting treatment is beneficial, but it did not reach the predefined clinical outcomes, so they were all considered as negative. And also, if you know about these ADAS-Cog scale, a difference of -1 after 2 years of treatment is really minimal. Our current therapy with the cholinesterase inhibitors, the effect size is about -4. So at least there's a 4-point improvements in the 6 months of the cholinesterase inhibitor treatment. So this is really minimal benefits compared to the placebo group. However, again, if we look at the subgroup, there are some signal that might be a little bit stronger in different measures. So the IADL is activities of daily living scale. So it seems to be some improvements in the treated group and maybe some benefits in the MMSE. But since these are not primary outcome, we don't consider them as positive. Safety is reasonable. So adverse event is about 16% in the treated group versus 18.9% in the placebo group. So these are older people with a lot of other health issues. So it is not uncommon to have adverse events in the 15 to 20% range. But one of these abnormality that we talk about is something called ARIA, which stands for amyloid-related imaging abnormality. And these are not easy to perceive. You have to get an MRI to find them. Sometimes people may have a bit of a headache. Sometimes people may actually have confusion and worsening of their cognitive symptoms. But a lot of times, these people are just asymptomatic. They are the usual. They are cognitive impaired because of the Alzheimer's disease, but it's nothing worse than usual. But we need to screen them with MRI scans. And in this particular study, it was relatively low. So there are the argument that perhaps this particular monoclonal antibody is not very strong. Whereas in another more publicized study by a different company, and they made this monoclonal antibody called aducanumab. It was very successful on a mouse model, so they moved on to a phase 1 study, and it was published in Nature in 2016, comparing a PET scan in the patients treated with a placebo versus someone who was treated with a high dose of this monoclonal antibody. And at the end of the study, you can see that red means a lot of binding of amyloid, and blue means there's very low binding of amyloid. And at the end of the study, in this particular patient, there's a significant less amyloid binding in the treatment group. And not only looking at a PET scan outcome, but also looking at a behavioral outcome, including MMSE score and CDR, which is a global measure of clinical function. There's also a dose response effect of the higher dose treated group have less decline in their function. So this is a small study with only about 100 people or so in a dose escalation study, phase 1. But based on these findings, the company has decided just to move on to a phase 3. So UBC is one of the sites that has recruited patients for this study, and we're currently monitoring the patient. It's close to recruitment now, but recently the company provided some longer-term open-label extension on this initial group of phase 1 patients. So if you didn't get these are the different outcome based on PET imaging. So if they did not get, or this is the placebo group, and they were started on the real treatment at the end of the phase 1 study with an open label extension, people can still benefit. So their PET amyloid binding seems to decrease after another 6 to 12 months. And those who were on the treatment with the higher dose seems to be staying lower, with up to about 70% reduction on their PET scan binding. And there seems to be some cognitive benefit correlation. So CDR is overall function, general function, and it seems like the highest dose seem to be doing the best. But there's a bit of irregularity in the MMSE because in the MMSE, it seems like the 6 milligram dose was not working very well. But 1, 3, and 10 milligrams seems to be having significant reduction. But things are as they are, so we don't know how to explain that. But now we are doing a phase 3 study that is using the highest dose, 10 milligrams per kilo. And we'll see what that shows in the future. Looking at the potential side effects, non-motor versus the number of side effects in different groups, it's clearly higher in the higher dose. So, and it's a bit lower in the placebo group. So there is some side effects associated with it. And the most worrisome side effect in this particular drug compared to the solanezumab is that about 30% of these people at the highest dose get these ARIA. And as I mentioned, they show up in MRI, and they don't really know sometimes. They are asymptomatic. Some of them will get confusion or headache. And up to 30% of the people, and also people who carry the ApoE4 gene are more likely to get these. So how we interpret this suggests that maybe the more severe patients tend to have more of these side effects. So if we try to treat people earlier in the milder stage, they'll probably have less side effects. It's still blinded, so we don't know. So we still have to follow up and see how many of these ARIA are causing problems. But at least in my own patient group here at UBC, when we see them in the scan and we stop the dosing for a month and then we started afterwards, they seem to be fine. So they don't seem to have any long-term problems. There are a number of different studies looking at the different monoclonal antibodies. Some of them are still being studied in different populations. So the DIAN and the A4 population are really looking at people asymptomatic before they have the disease, but they carry a risk factor. So the A4, if they actually have a positive amyloid brain scan, that would be a risk factor for them to get worse in the future. Or in the DIAN study, when people have a mutation, one of the major mutations that cause early onset Alzheimer's disease. So if they live long enough, they're most likely going to get Alzheimer's. So we're treating them in the asymptomatic phase to see if we can actually prevent or delay the onset of Alzheimer's. For the BACE inhibitors, most of them have been negative. And I just highlight one of the recent one that was again on the news that it was highly publicized and was negative. And this one, in another subgroup analysis, there seems to be some benefit in amyloid uptick, but the clinical outcome, which is the memory scale and the activities of daily living scale, were negative. So it was considered negative. Some people still want to look at the silver lining, and if we look at subgroup analysis, there are some benefits when we look at people who are PET, who have a PET scan follow-up, and if they look at their PET changes, there seems to be some changes, but the clinical are really parallel, so there's not much difference in the clinical outcome. So in summary, I've shown you that Alzheimer's disease, as we understand it, is still quite complex. There are many risk factors involved. Some of them are potentially reversible and treatable, like the vascular risk factors. And since vascular risk factors are relatively safe to treat, I think the controversies of how low blood pressure should you achieve is still a little bit controversial. And this new finding of aiming for a target of 120 is quite new because most other data suggests that 140 is probably good enough, but 140, you're at risk of getting more side effects if you push too much medications on the patient. Similarly, how well we treat diabetes is also a bit controversial. And there are studies suggesting that if you push the A1C to 7 or less, then their vascular risk factors and stroke all the brain diseases tend to have less outcome or less incidence if you treat them well. But then the side effects are also higher if you push them too hard to control the diabetes. So there are still some controversies, but in general, I think everyone should try and get their patient to monitor their vascular risk factors and then get them up in exercise and continue with being brain active and physical active. Brain activity would be working longer or doing lots of hobbies in your time outside. So don't just sit around and watch TV and learn languages, play musical instruments. Those are all positive psychosocial activities. For the pharmacological treatment, I haven't gone through all the negative studies of Alzheimer's treatment, but most of the negative studies were at a later phase. So when we actually diagnose patients with Alzheimer's disease, they're already scoring below a certain level, usually an MMSE of 24 or less. So at that time, they're quite significantly affected. And almost 100% of those studies are all negative. And it seems like most of the positive silver lining are in the mild cognitive impairment or the MCI due to Alzheimer's. So we need to treat people much earlier. So we might be able to stop the progression of these patients if we treat them early, but we are unlikely to reverse Alzheimer's disease if they already have Alzheimer's disease. But then that leads to another question. So if they're normal, how do we know that they're going to be progressing? So a lot of the parallel research are on biomarkers, which is another topic on its own, which I don't have time to touch on. But if we can use the biomarkers properly to predict people at the very earliest phase and differentiate those who are not at risk so that we're not subjecting them to unnecessary treatment, then that may be the most likely way to be successful. I think there should be parallel development of biomarkers to help to diagnose and predict these patients at the very early stage before they are actually cognitive impaired with Alzheimer's disease. Then we may be able to find a feasible treatment. Until then, there are lots of other things that are being done to try to understand the disease process. And I think we may also need multiple agents to eventually to be successful. So today I just focused on the amyloid hypothesis and we haven't talked about tau. But tau may be involved in more different types of dementia, and having some way to reduce the tau pathology may also be helpful. So it will be kind of like the cancer and HIV model. You may need a 3 or 4 combination treatment to be effectively lowering the dementia risk before we can actually prevent the disease. So that's the end. And I would like to thank my funders and also other people helping out in many of these studies. Thank you. So, questions?
I have one in Victoria. Hello?
Yes, go ahead.
Victoria, thank you for tackling such an important and difficult problem. Can you comment on the fact that some people with florid pathology are cognitively normal? That's number one. Number two, the cynic would say the best treatment is smoking because people die before they develop the disease.
So, yes, smoking is a risk factor for developing the disease, but in epidemiological studies, they tend to be lower, and I think it's exactly right because they die with another disease, so they don't get old enough to develop Alzheimer's disease. But smoking has nicotine, and nicotine is a acetylcholine agonist. So some people argue, at least the smokers argue, that there's some benefits to their cognitive function when you use nicotine. But because of the other things in smoke, all the carcinogen and things that are bad for your lungs, I wouldn't advise that as a treatment. As for your other question, that was about sorry, remind me, what was the question?
Chris, about the specificity of the pathology.
Oh, yes. So there are some studies suggesting that people with Alzheimer's pathology actually does not have cognitive impairment. And yes, there are some cases suggesting that, but more and more with the longitudinal studies, it suggests that if you actually live long enough, you will eventually get Alzheimer's with these pathology. But that has another thing that goes on, which I didn't talk about, is the cognitive reserve. So people who have a high cognitive reserve can probably live with this pathology for a longer time until a later stage of the pathology when they become cognitively impaired. And that's when the educational attainment may come in. So if you are destined to accumulate amyloid anyway, but if you have a lot of cognitive reserve, you may be able to function and compensate better until a later stage of pathology. So that might be what these cognitive training are trying to do, is to preserve cognitive function despite the pathology.
Sorry, the microphone's not working here, but you mentioned hyperlipidemia as a vascular risk factor. What's the net role of statin therapy, do you think, on dementia?
Right. So in the actual clinical trial, looking at statin and treating patients already at Alzheimer's, it has been negative. So a big study by atorvastatin was negative. And another more recent one, I think, is to look at Crestor. So these are the secondary prevention. So people are already diagnosed with Alzheimer's, and we hope to slow down their treatment, slow down their progression. They don't seem to work. We don't have a large-scale prevention study yet, but looking at epidemiological data in the younger population, so treating people at 40 to 60 years of age, epidemiologically, those people seem to have less dementia when they reach 60 to 80. But those are not randomized. Those are cohort studies. In order to do a full randomized study, it will be quite long and expensive. Yes?
Sorry, the microphone isn't working. Just in the last few days, there's been headlines that the herpes simplex virus may be a significant risk factor for Alzheimer's. Do you have any comments on that?
So it has been coming in and out of vogue. So for a number of years, infection and Alzheimer's disease, there's a correlation. So not just herpes, but chlamydia has also been implicated, and they seem to coexist in some of these amyloid plaque pathology. But the difficulty of showing that is the high prevalence of these diseases. So not the treponema, chlamydia, but psittacosis. That is quite common, and people can get it without any treatment, and they don't even know about it. So it's quite common, and herpes simplex 1 and 2 are also quite prevalent. So it's very hard to do a proper epidemiological study to see if it's actually causing it. At least there's no good model to link herpes infection to amyloid production. But it leads to another risk factors. Chronic herpes may cause persistent inflammation. So one of the other line of risk factors, chronic inflammation. So it may promote chronic inflammation and increases risk of disease by that pathway. But I don't think there's enough data to be of proof yet. All right. One more?
Maybe a quick one. Do the monoclonal antibodies, are they given systemically or intrathecally?
So all of those are given systemically. How well it crosses the blood-brain barrier is a big question. Some of the newer ones seem to cross the blood-brain barrier better, and some of the older ones doesn't seem to cross it. The company that designed the drug argued that it's a sink hypothesis. So even if it doesn't cross the blood-brain barrier, if it removes all the amyloid in your vascular system, it will secondarily remove it through the blood-brain barrier. Whether that is true or not, we don't know. On the other hand, the aducanumab seems to cross it better, but it also causes more side effects, and that's the drug that has the most ARIA complication. But that is the drug that seems to have the best clinical outcome so far. So maybe we actually need to have it crossing the blood-brain barrier and cause a bit of side effects in order to have it work. So we don't really know that yet, but we're waiting for the results. Thank you.
So do you think there's another mechanism entirely that just hasn't been discovered? Because the PS1 and PS2 and the mouse models, that you know what's happening, but what about there's another completely different?
Yeah, so I kind of mentioned the missing link between amyloid and tau.
Yeah.
So the mouse model can mimic amyloid, but the mouse don't have tau pathology.
Yeah.
People argue that you have to live much longer in order to...
So they're probably working together.
Yeah, so somehow amyloid will lead to tau production and the eventual cell death. And tau correlates to cognitive impairment much better than amyloid.
Because you're only targeting one thing.
Yes. Yeah.
You probably need...
Oh, I noted.
I know. We're coming down to disguise. We're still filming my relatives.
Thank you for your support.
Are you on service here today? Or?
No, I'm just teaching.
Oh, okay. Also, are you going to be there tomorrow morning?
Yes, I'll be there tomorrow morning.
I want to pick your brain about a few questions about your faculty here, last year and St. Paul's to get everything set up.
Okay.
We'll bug you tomorrow.
Okay.
Hi, I'm Jovi. I'm a medical student in third year. I'm interested in applying for neurology. I'm planning to. I'm interested in dementia research as well. My background is I did a PhD in medium minutes.
Oh, okay.
Yeah, so it's interesting too because dementia is what is people doing.
Yeah, there are lots of new studies about sleep and how sleep matters. All these are pathology.
Yeah. So anyway, I'm hoping to be a clinician scientist eventually. I know I'm like really early in my
Good
training.
goal.
But so, and then I know you're doing so much dementia research, so just wondering if I can shadow you sometime or maybe see your lab or something.
Okay, email me.
Okay, I'll do that.
Write it down.
Oh, it's okay. I found your email.
Oh,
yeah.
Yeah.
Okay. And do you do wet lab work or mostly clinical trials?
Mostly is clinical research with some collaboration with Dr. Dept, so we work together on some of the biomarkers. So I have a small lab, but I don't do all of the lab things. But most of the lab is really just running some ELISA assays and collecting the samples.
Okay.
And occasionally I do some genetics, not the high throughput, just looking at specific genetic receptors.
Okay, cool. Another thing is that I was, because I do some ophthalmology research, and the circadian rhythm research I did was retinol.
Mm-hmm.
So I know like they're doing some biomarkers in the eye as well.
Yes.
I don't know if they're collaborating with you on that.
Yes, I'm working with Dr. Matsudawa.
Yeah, exactly.
Eye care department.
Your call will be disconnected.